Good day, students. I am Dr. Lisa Kalimag. Today, I will be lecturing on the biopsychosocial paradigm of care, as well as the patient-centered, family-focused, and community-oriented healthcare. These are the objectives of this lecture. At the end of the session, the students shall be able to differentiate the biomedical model and the biopsychosocial model, identify biological, psychological, and social factors that influence health, and apply the biopsychosocial approach to the holistic care of a patient and his or her family and community. That is the patient centered, family focused, and community oriented healthcare. First, let us discuss the traditional medical model, which is the biomedical model. The biomedical model is rooted in medical practice 4 centuries ago when physicians were allowed to dissect the human body. The biomedical model believed that understanding a complex entity, such as the human body, can be achieved by analyzing its component parts. They would study the human body and its components using physics and chemistry. The person or the human body is a complex entity. This can be divided into the organ systems, which are then divided into organs, followed by tissues and cells, and so on. The biomedical model seeks to understand the human body using this framework in order to keep the patients healthy. But first, how do you define health? This is the definition of health according to the World Health Organization. Health is defined as the highest possible level or state of complete physical, mental, and social well-being, and not merely the absence of disease. There are other definitions of health, but for this lecture, keep in mind this definition. Now we move forward from the biomedical model to the biopsychosocial model, which was proposed by the psychiatrist Dr. George Engel. This model says that neither disease nor illness is understandable only in terms of smaller and smaller biological components. This model emphasizes the unity of the body, mind, and social context. A person's response to a disease requires consideration of factors such as the social and cultural environment, the individual's psychological resources, and the biochemistry and genetics of the disorder in the population. You can then analyze patients not just in terms of their component parts, but through this macro scale, from the biosphere to the society or nation, to the community, the family, two persons, and the person. As an example, you have a workplace accident. You could look at it in terms of poorly designed equipment, which is the social aspect, and suppose there was inattentiveness on the patient's part, which is psychologic. And the inattentiveness of the patient may have been caused by low blood sugar, which is biologic. So that is how you look at the patient and their situation in a holistic way. The biopsychosocial approach does not attempt to replace the traditional way of approaching medicine, but it tries to go further by taking a whole person approach or a holistic approach to manage patients and their various medical conditions. In the next slides, we will be discussing the biological factors, psychological factors, and social factors affecting health. Biological factors include demographic profiles such as age, sex, marital status and parity, race, and occupation. Biological factors also include genetic characteristics, environmental characteristics, and lifestyle characteristics. As an example, under demographic profile, we know that having the following characteristics are associated with reduced mortality from nearly all diseases: of having female sex, being married, higher socioeconomic status, and greater number of social ties are associated with reduced mortality from nearly all diseases. As for age, we know that older age is associated with hypertension, diabetes, coronary artery disease, chronic kidney disease, and most cancers. While the younger age are more susceptible to streptococcal throat infection, many infectious diseases, hence we have the expanded program of immunization for children, and they are susceptible to certain types of leukemia. For sex or gender, we know that there are diseases that are associated with menopause, such as cardiovascular disease and osteoporosis. Of course, we have the obvious fact that men can have prostate cancer, while women can have breast cancer. So you should have different screening programs for each sex. Nulliparity, or never having given birth, is associated with increased risk of breast cancer. While for the opposite end of the spectrum, which is having too many births, 5 or more, this is called grand multiparity, there are some studies that they are associated with adverse maternal outcomes, but it may also just be due to their older age. Of course, we have genetic characteristics that predispose to certain diseases. For example, we have these congenital diseases, among others, in the Philippines, hence the importance of the newborn screening program in order to facilitate early interventions for the children. Finally, we have lifestyle characteristics such as the following, which predispose to various diseases: alcoholism, substance use and abuse, smoking, lack of exercise and physical activity, and diet, either overnutrition or undernutrition. Moving on to psychological factors, we have the affective dimension, which is your feelings, cognitive, which is your beliefs and knowledge and expectations, and the behavioral dimension. The patient's defense mechanisms and coping styles also influence their health and illness. The health beliefs of people influence their health seeking behavior. We should identify the health beliefs of patients, correct any existing misperceptions regarding their illnesses in order to improve their behavior. For example, you still have a lot of patients that say that they don't want to take any medications as much as possible because they believe that ang mga gamot nakakasira ng kidney and that herbal medications are safer because they are natural. These patients may consult a doctor when their disease is already advanced, or they will not take the medicines that you prescribe. So you have to correct their misperception about the safe doses of medicines. You can say that these have been studied in clinical trials, and maybe they had misunderstood about the renal dosing of drugs, in which you reduce the dose because the patient already has kidney disease. But technically, the medicines do not cause the kidney disease themselves. Filipinos have many traditional beliefs about healing, such as these mentioned. For my discipline, which is family medicine, we do not belittle nor mock these beliefs. We respect them. But we emphasize the evidence-based medicine, and they can add on the alternative medicine if they wish, as long as it doesn't obviously cause them harm. Personally, I warn them the most about the lack of studies for herbal medicine because that's oral intake and I think more susceptible to adverse drug effects. But Filipinos may feel comforted by practicing these traditional beliefs, and it could improve their well-being. These are other modalities of Filipino healing. You can see here the suob or tuob or steam inhalation, which was used by many people during the COVID pandemic. How do you address psychological problems brought about by misperceptions of patients about their disease? So we can do primary care counseling, which is a face-to-face psychoeducation method. It brings out the psychological concerns that result from a misperception of reality that hinders appropriate behavior. This is what we call emotionally critical misperceptions or ECMs. The example I gave earlier of a patient believing that medicines cause kidney damage is an example of an ECM. If ECMs are addressed appropriately, barriers are lifted, and educational inputs are better received. These methods are derived from Carl Rogers' person-centered psychotherapy. Primary care counseling can be through CEA or CIA. So CEA counseling stands for catharsis, education, and action. Please take note of these steps. Whereas CIA counseling stands for catharsis, insight, and action. So how do you do this? In catharsis, you first ask for the patient's thoughts, feelings, and fears about their illness. Then you identify the emotionally critical misperception. Then you either educate the patient or they get the insight on their own after the catharsis. And then for action, together, you create an action plan on the behaviors that should be corrected. So it's important to start first with catharsis so that the patient can unload all their worries, all their fears, and then you will be able to identify the emotionally critical misperception and you know what to educate them on. Because sometimes we educate them on something, but then that's not the issue. So that's why it's important to start with catharsis first and understanding what is really on the patient's mind. In this method, it is important for the counselor to show genuineness, unconditional positive regard, and empathy. Unconditional positive regard means you let go of all your judgments towards the patient, even if they have wrong beliefs. And you look at them in a positive light or you see the best in them. But if you show judgment towards the patient, the counseling will not be effective. The counselor should also employ active listening skills such as nonverbal cues to let the patient know that you are listening. We will now move on to social factors, primarily regarding the family. I will be introducing you to the concepts of family structure, family life cycle, family assessment tools, as well as the impact of illness and illness trajectory. These social factors affect the quality of life of individuals. So why do we give attention or importance to family characteristics? The WHO recognizes the family as the primary social agent in the promotion of health and well-being, as well as disease prevention. The family influences a person's health beliefs and health-related behaviors. It's common for health beliefs and behaviors to be shared across the family, whether these are positive or negative. Things such as when do you see a doctor, what is your diet, what are the exercise practices, these are commonly shared among the family. The family can also be either a source of stress and a source of support in times of illness. How do you define a family to begin with? The classical definition of family is that of biological and marital kinship, along with patterns of reciprocal obligations. So basically, you are biologically related or married, and you take care of each other. But the emphasis is on the biologic and procreative relationships, as well as the child rearing structure. In the modern definition, a family is a small social system made up of individuals related to each other by reason of strong reciprocal affections and loyalties, and comprising a permanent household that persists over years and decades. So it's a wider definition, and they don't necessarily need to be blood related. So this is a more modern definition. For example, you have same-sex couples with children, unmarried couples with children, couples with stepchildren, and single parents with children. We can describe a family in terms of family structure. For nuclear family, you have the parents and their dependent children. For extended family, this includes three generations. You have the grandparents, parents, and children in one household. So it can be unilateral, one side of the family only, or bilateral. So on the wife, there is a grandparent, and on the part of the husband, there's also another grandparent. That would be bilateral. A blended family includes step parents and stepchildren, and you have the single parent family. For communal or corporate family, it is a group of individuals formed for specific ideological or societal purposes. It's an alternative lifestyle for people who feel alienated from the predominantly economically oriented society. So, an example of this is the Amish community in the US. Here are some clinical correlates. So, being a single parent is associated with higher death rates due to cardiovascular diseases, malignancies, infectious diseases, accidents, homicides, and suicides. While being widowed is associated with 4 times higher age-specific death rates compared to married individuals. Divorced men have increased rates of depression, suicides, and domestic violence, while stepchildren or children of single parents are associated with having developmental delay, that is autism spectrum disorder, attention deficit hyperreactive disorder, depression, and adjustment disorders. One aspect of studying families is the family life cycle. The family life cycle shows the evolution of the marital relationship and the evolving family unit. Each stage of the family life cycle has an emotional process of transition in which the key element is adapting to the new situation. So this is the 6-stage family life cycle. First, there is the unattached young adult, when a person leaves their family of origin to live by themselves independently. That could be most of you listening to this lecture. When the young adult gets married, they move to the next stage and form a family unit with their spouse to be the newly married couple. Once they have children, they will again need to adapt to the responsibilities of the stage, primarily adjusting to parenting. This stage is called family with young children. When their children grow up to be teenagers, that will then be called the stage called family with adolescents. Because teenagers have different needs as compared to young children, they need more independence. So this is a unique stage. And once the original married couple's eldest child grow further into adults and eventually leave the nest, the original couple is now in the launching family stage. While the one who left will start their own life cycle as an unattached young adult. Once the original married couple has launched all their children, they are now a family in the later years. At this stage, they should be preparing for death and bereavement. So that is the family life cycle. Each stage has an emotional process of transition, and the key element is adaptation to the new roles and responsibilities, circumstances in each stage. These are the family assessment tools that we can use to study and describe the family. But I will not be discussing all of them since this is just an overview of the family assessment tools. So you have the genogram or family tree, family map, family lifeline, family APGAR. Family APGAR assesses the family function, and the family scream assesses the family resources. Similar to the scream family resource survey is a modification of the scream, original scream. So first we have the family genogram or family tree. Here are some of the symbols that we can use to describe the family and its members. So you have square for males and circle for females, and an X mark for death. We also have symbols denoting marriage, symbols denoting divorce, separation, living together. Most importantly, you should create symbols for the diseases, especially hereditary diseases in the family. So this one is an example of a genogram, and you can see the occurrence of heart disease in color red and diabetes, color green, in the family. So this pertains to another family assessment tool, which is the family map. In a family map, you describe the relationships between family members, as well as the boundaries between each member, whether rigid, clear, or diffuse. You can also have coalitions, conflicts, detouring, and over-involvement. There's also what we call the illness trajectory and the impact of illness on the patient and the family. Knowledge of the trajectory allows the primary care physician to predict, anticipate, and deal with the family's response to the disease or illness, and eventually enables the primary care physician to formulate individualized therapeutic plans. These are the stages of illness trajectory. First, you have the onset of illness, when the patient starts to feel symptoms of any kind, but they haven't consulted a doctor yet. Sometimes it takes them a long time in the onset of illness where they don't want to consult a doctor. For example, a patient being constipated and having rectal bleeding for 1 month before they consult a doctor. Then when they consult a doctor and get diagnosed, they go to the impact phase or reaction to diagnosis. For example, they get diagnosed with colorectal cancer, and this is where they have to deal with all the anguish and turmoil of the diagnosis. Then when you go to major therapeutic efforts, the patient, with the help of their family, is focused on the treatments. For example, surgery, chemotherapy, and other medications. Then the patient either recovers and goes to the recovery phase, or they have a bad outcome, such as disability, or they could be bedridden. Now the family will have to support the patient in that outcome. So that is adjustment to the permanency of outcome. Particularly in cases like cancer, stroke, and other life-threatening illnesses, we can help the patient and their family go through this trajectory of illness and all the pitfalls and struggles that come with each stage. There is a field of medicine, which is hospice and palliative medicine, which actually focuses on providing support and care for terminally ill patients, such as the one I discussed, as well as their families. In hospice and palliative medicine, the goal is not anymore to cure the patient, but for them to live as fully and as comfortably as possible with the least amount of pain. We also want them to attain a degree of mental and spiritual preparation for death. Some of the ways to do this is through discussing their advanced directives. For example, whether they want to be intubated or if they want to have CPR or resuscitation done on them, and who will be their surrogate decision makers when the time comes that they cannot decide on their own. How do we summarize the biopsychosocial approach? In our discipline, that's family medicine, we use the PFC approach. PFC stands for patient-centered, family-focused, community-oriented care. Please take note of that. This slide, let's look first at patient-centered care. Of course, you have your history and physical exam. So that's the medical component or the biomedical component. But we also add to that asking about the patient's fears, doubts, concerns, and predicaments. For analysis, we come up with a primary working impression and differential diagnosis. And we identify the stage of the trajectory of illness and the impact of illness. For management, we order diagnostics, we treat the patient pharmacologically and also non-pharmacologically, such as health education and counseling if needed. Next, we have the family-focused care. We look at the family determinants and resources. We look for possible caregiver issues. We analyze with the family assessment tools, family life cycle, and the impact of illness on the family. For plan of management, we can do capability building of caregivers, health education for the family, and family counseling if necessary. Lastly, we have the community-oriented healthcare. I didn't really discuss this during this lecture because it's too broad, but technically it's part of the biopsychosocial model and it's also part of the patient-centered, family-focused, community-oriented model. But since you will be having more lectures on these topics in the future, especially in your third year, you will have a whole semester for community medicine in order to understand all of these things. But as an introduction, we should look at the home and work environment, such as the sanitation, the social determinants for health, such as the socioeconomic status, education, housing, etc. The building blocks of health systems, you will be taught that later on. Health laws, how it impacts the patient, and epidemiologic data. So what diseases are prevalent in the community of the patient? Is there a lot of dengue cases? Are there a lot of leptospirosis cases? Are there substance abuse cases, etc.? Then for analysis, we summarize all of these into whether they are enablers or barriers to care in the community. And we manage the patient by referring or linking the patient to services that can help, such as PhilHealth, DSWD, senior citizens organizations, NGOs, community exercise programs, etc. And we strive to have an interprofessional and multidisciplinary team approach to promoting health and well-being in the patient. This is my last slide. Thank you for listening. Kindly accomplish the faculty evaluation after the lecture and see you on the synchronous session. Thank you.